Epinephrine by Robert Burke for 1149-09 Advanced EMS Pharmacology. Epinephrine, also called adrenaline, is a hormone that is secreted mainly by the medulla of the adrenal glands and functions primarily as a vasopressor to increase cardiac output and to raise glucose levels in the blood. Epinephrine typically is released during acute stress, and its stimulatory effect fortifies and prepares an individual for either fight or flight responses. But before we dive in, we need to clear one thing up. Is it called epinephrine? Is it called adrenaline? The answer is a definite yes. You see, in 1901, Jagochi Takamine patented a purified extract from adrenal glands and called it adrenaline, from the Latin ad and renal, meaning near the kidneys. The US and Britain approved it. However, the pharmacologist John Abel had already prepared an extract from the adrenal glands as early as 1897 and coined the name epinephrine to describe it from the Greek epi and nephros, meaning top of the kidneys. Therefore, epinephrine became the generic name in the US. European health professionals and scientists use the term adrenaline, and American health professionals and scientists use the term epinephrine. So essentially they are interchangeable. They sound weird at times. Adrenaline concentrations in resting adults are normally less than 10 nanograms per liter, but may increase by tenfold during exercise and by 50-fold or more during times of stress. The major physiologic triggers of adrenaline release center upon stresses such as physical threat, excitement, noise, bright lights, and/or low ambient temperatures. Epinephrine is a key stimulatory component of the sympathetic nervous system, hence their pharmacological classification as sympathomimetic agents. The actions of epinephrine are complex, owing to its stimulatory effects on A and B adrenergic receptors, which produce various responses, depending on the specific receptor and the tissues in which it recurs. Epinephrine causes constriction in many networks of the minute blood vessels, but dilates the blood vessels in the skeletal muscles and the liver. In the heart, it increases the rate and force of contraction, thus increasing the output of blood and raising blood pressure. In the liver, epinephrine stimulates the breakdown of glycogen to glucose, resulting in an increase in glucose levels in the blood. It also acts to increase the level of circulating free fatty acids. The extra amounts of glucose and fatty acids can be used by the body as fuel in times of stress or danger, when increased alertness and exertion are required. The physiological actions of epinephrine are terminated metabolically, and reuptake occurs at the nerve endings and by diffusion from active sites. In medicine, epinephrine has two well-known therapeutic uses: cardiac arrest and anaphylaxis. Most people outside of the medical world are familiar with epinephrine from the epinephrine autoinjector or EpiPen. These pens are used to deliver 0.3 milligrams of epinephrine each to medically treat a significant type of allergic reaction called anaphylaxis. The device injects subcutaneously or intramuscularly. It is usually injected as needed at the first sign of serious allergic reaction. The injected epinephrine narrows blood vessels and opens airways in the lungs. These effects can reverse severe low blood pressure, wheezing, and severe skin itching, hives, and other symptoms of allergic reaction. The therapeutic use for epinephrine is the treatment of cardiac arrest. Epinephrine is a commonly administered vasopressor in cardiac arrests. Non-selective alpha and beta agonist. It exerts chronotropy and inotropy effects via alpha-1 and the beta receptors. Alpha-1 receptor activation can cause coronary vasoconstriction, while beta receptor activation can cause coronary artery vasodilation. Although the chronotropy and inotropy provided by the epinephrine are in theory beneficial to a patient in cardiac arrest, research has shown that the alpha-1 mediated vasoconstriction is what truly benefits these patients by driving up the coronary perfusion pressure. First uses in cardiac arrest were documented in 1906, in which it was demonstrated that compared with artificial ventilation and cardiac massage alone, the infusion of epinephrine greatly increased the proportion of resuscitated dogs. Prior to that, European researchers had described vasoconstrictive attributes of the adrenal gland extracts. In 1896, after thoracic compressions and adrenal extract was used to resuscitate an asystolic rabbit, adrenaline was proposed for use in humans. The role of epinephrine in cardiac arrest resuscitation continues to evolve. Questions include how much to give, how often to give it, and how early to give it, and even if it should be administered at all in cardiac arrest. Even with the potentially beneficial effects in cardiac arrest by augmenting coronary blood flow and increasing the chance of ROSC, potentially harmful effects on the heart are mediated through B adrenergic stimulation, which causes dysrhythmias and increased myocardial oxygen demand and increases the risk of recurrent cardiac arrest. In addition, A adrenergic stimulation causes platelet activation, which promotes thrombosis and impairs the microvascular blood flow in the cerebral cortex, which in turn increases the severity of cerebral ischemia during CPR and ROSC. Indeed, recent studies have shown increased neurological damage to cardiac patients that received epinephrine as opposed to a placebo. While epinephrine use has been shown to increase the chance of ROSC, it has not been shown to improve survival to the hospital discharge nor neurological outcome.